Welcome to Bad to the Bones, the podcast where we discuss everything related to orthopedics, joint health, and living an active lifestyle. Welcome to Bad to the Bones podcast. I'm your host, Debra. On today's episode, Dr. Mohamed Albana will share the benefits of robotic total joint replacement and his approach to treating arthritis. Dr. Albana provides the most advanced treatments and technology available in the field of adult hip and knee replacements, right? Hip and knee replacements, yes. He specializes in robotic partial and total knee and hip replacements, complex joint replacement and reconstruction, revision of prosthetic joint infections, and arthroscopic knee surgery. Welcome to the show, Dr. Albana.
Thank you very much.
We're so happy to have you here. So you're new with us. You just started September 3rd, and we're so proud to have you on board. You bring a lot of expertise and just new technology that you with the robotic assisted surgery. So when you did your research on which practice to join and where you wanted to share your skills, what led you to Premier?
Well, first and foremost, thank you for having me here. Mm-hmm. It's very nice to finally be back in the area. I did do my training down in the area, and so a lot of my now senior partners trained me before I went off to fellowship to specialize in hip and knee reconstruction. So in talking to a lot of practices, I kind of got a sense of the other side of medicine, kind of the business world and how much growth there can or can't be for a particular practice. And how much support the physicians within a practice have for one another. And the family-like structure of Premier was very important for me. There's sure. The physicians of all subspecialties have a great relationship with each other, cover each other for call if it's needed, and have a plethora of experience to kind of talk about more complex cases that arise.
There's really good collaboration at Premier. I've noticed of the doctors, just everybody works together from PT, the PAs, like everybody, there's just really great collaboration. Is that something you noticed?
Yeah, absolutely.
Yeah, it's really a breath of fresh air, actually, from what I see. So what sparked your interest in choosing the subspecialty of total joint replacement?
Well, orthopedics is a long path. You get exposure to everything from trauma to foot and ankle, pediatrics, oncology, spine. And one of the biggest things for joints was the ability to get patients back to their activity level pretty quickly and reliably. And that was always huge for me. You have a patient who's coming in with a ton of pain in their hip or their knee, and shortly after a replacement, they have pain, but it's a different type of pain for a short period of time as they're kind of rehabbing through surgery. So that was definitely what drew me to joints. And the other thing, I think there's within orthopedics, everyone kind of knows that each subspecialty has certain stereotypes, and the joints people tend to be very OCD. Attention to detail was very important for us, and that drew me to the field for sure.
So let's talk about arthritis. A lot of these joints, they are prone to arthritis. So can you talk a little bit about what is the difference between osteoarthritis and rheumatoid arthritis?
That is a great question. So arthritis in general just means that the cartilage that lines a bone is worn out and it exposes the bone that sits beneath that cartilage. So the knee is very easy to kind of conceptualize. You have your thigh bone and it sits on top of the shin bone, and each of those bones has a coat of arthritis. And between those two bones are two C-shaped pieces of cartilage that essentially act like a rubber gasket. And as that wears out, the cartilage that lines the bone then wears out. Cartilage doesn't have any nerve endings. And so patients don't feel that. What they're feeling is the bone underneath when it gets exposed and the weight is going through those bones. So that is arthritis, generally speaking. So osteoarthritis is just wear and tear.
Okay.
Rheumatoid arthritis, psoriatic arthritis, any of the inflammatory arthropathies, those are autoimmune. And so that means that the immune system, for some reason, is attacking the joints and wearing out the cartilage.
Okay. And so would you say that most of us are susceptible to arthritis at some point in our aging process?
Generally speaking, yes. But just because someone has arthritis doesn't mean that you necessarily have to do anything about the arthritis.
Yeah.
Arthritis can be defined as something seen on X-ray.
Yeah.
But that doesn't necessarily mean that a patient is symptomatic from arthritis. So the short answer is yes. The long answer is yes, but not everyone is affected.
Okay. And so in your experience, what are some of the major, what's some of the major impacts that having arthritis, one or the other type, has on someone's quality of life?
Depending on how severe the arthritis is, it could be completely debilitating.
Yeah.
So we'll go back to the knee again. Simple things that we do on a daily basis, like going up and down stairs, getting up from a seated position, whether it's eating breakfast at the table or using the bathroom.
Yeah.
The amount of force that goes through the knees goes up from 1 time a patient's body weight when they're just standing to 7 times their body weight. And so any exposure of that bone that sits under the cartilage, that bone is seeing 7 times the body weight in normal activities of daily living.
Yeah.
That's not running and jumping, which can see up to 25 times a patient's body weight. So a lot of patients come in complaining of those things. Can't go up and down stairs, can't get up from a seated position, hard to put on my shoes and socks. I can't get in and out of a car.
Yeah.
So it can be very debilitating for sure.
And when a person comes in for an initial consultation, what can they expect that evaluation process to look like when they're being evaluated for arthritis?
So most of the time, by the time the patient gets to me, they have some sort of imaging. Typically, we start with x-rays. So the patient comes in, I take a look at the x-rays, I walk into the room, and we start having a conversation about what the complaints are.
Yeah.
So the most important thing is going to be the patient's history. Why are you here? What's bothering you? How bad is it? Then we go into the physical exam. What provocative tests or maneuvers that I do in my physical exam make your symptoms worse?
Mm-hmm.
That helps me get to a general idea as to what's going on.
Yeah.
From that point, we have a kind of split as to where we go. Most of the time, we try non-operative measures, whether that's medications over the counter, physical therapy, injections. If those don't work, then we start talking about surgery. I like to typically just lay everything out for the patient, and we go through the decision process together.
Yeah.
Because in the end of the day, this pathology is really a quality of life thing. We're not going to rush anyone to the operating room to replace a joint.
Yeah.
It's how much is this affecting your life, and is it worth a surgery for you? So that shared decision making really drives the treatment.
So when you're doing your initial evaluation, can you sometimes tell just from the evaluation what type of arthritis they have? Or is that really where the tests come into play?
The physical exam is very important.
Yeah.
Even looking at a patient walk, which I try to see patients walk all the time, to whether it's coming back to the room or I have them get up from the seat to get onto the examination table, you get a sense of how much the arthritis is affecting their gait, which
Mm-hmm.
that's the only way to get around, right?
Yeah.
You can't really tell what's happening, but you could tell that there's pain. And there's different types of gait patterns, whether it's a hip arthritis or knee arthritis. But you could also tell deformity of the leg. So if someone has knock knees or they have bow legs, you could see how their knees move. and that affects the whole limb as a patient's walking.
Yeah.
So just from looking at a patient, you can't really tell. It's a combination of the exam and the x-rays to start.
And so as you mentioned, it's a collaboration between the patient and yourself about the treatment plan that you think is going to be best for them based on what their outcome, what their lifestyle is that they want to return to and where they are in pain, in their pain level.
Mm-hmm.
So what would a typical, if someone comes in and it's their first appointment, you're evaluating them for arthritis and you can clearly see they have it even before the x-rays and such. What does a treatment plan look like? I mean, is it PT first and then pain medication or pain management? How does that go?
So I will typically, part of my questions in my history is how much pain do you have from 1 to 10?
Yeah.
10 being cut the leg off, I'm done with it.
Yeah.
And based on that response, I gauge if a patient should get an injection or not.
Okay.
Injections are relatively low on the risk profile, but they still do carry risks. So if a patient comes in with 2 or 3 out of 10 pain, I typically veer away from injections. Mm-hmm. Unless they've tried all the other options, which I mentioned them, the physical therapy, anti-inflammatories, over-the-counter, and then there's also prescription strength. And then weight management is a big one as well. Yeah. If those things aren't working, then we could try injections. After the injections, there's really no other path other than surgery. So either the injections are working and we can keep doing them, or we start talking about surgery.
But it sounds like the injections and the pain management, it's really just, is it delaying surgery? Because ultimately the cartilage doesn't regenerate, correct?
Correct.
So it's really just trying to manage someone's pain and putting off surgery?
Yes.
Okay.
That's the short answer.
Yeah.
The longer answer to kind of understand, a lot of patients come in and say, hey, my knee's bothering me. It's not killing me, but I want to have surgery while I'm young.
Yeah.
And, we're surgeons. We love to operate, but I just don't think that's the right thing for the patient.
Yeah, and I think patients respect that.
Yeah.
Appreciate that.
There is a risk of revision surgery in the future. And a revision surgery basically is a redo of the replacement.
Yeah.
Those carry much higher risk than a regular knee replacement. So if it's a matter of, my knee's nagging me, I'm still able to play tennis, hike, and do everything that I want to do, it's just bothering me and I want this done before I get old and unhealthy.
Right.
We have a conversation about why that's probably not the best idea for that particular patient.
Yeah. But so if you have a patient that comes in and like you were, saying earlier, like, oh my gosh, my pain is so bad, just take my leg, right? I mean, obviously that's figure of speech. But if they come in at that point where they've just been living in pain for too long, is it okay if they say, you know what, I just want to forego all of this preliminary stuff, just take me to surgery?
Yes, that is reasonable in some cases. And it's really patient dependent.
Yeah.
But in a patient who we're assuming has 8, 9, 10 out of 10 pain, they're not going to tolerate physical therapy.
Yeah.
And medications by mouth really aren't going to help.
Yeah.
And the one thing I didn't say about injections are an injection may or may not work. But if you get a steroid injection, you can't get surgery for 3 months.
Oh, okay.
Because there's a risk of infection.
Yeah.
And so I tell patients that, and the idea is, are you willing to get an injection now with it working for a few days and then not be able to do anything for 3 months? Mm. Or are you done with the pain and want to move forward with surgery? So that's a very important delineation that's really patient dependent.
Yeah.
And that's kind of how I go about it.
Wow. That's a huge consideration, for a patient to think like this is short-term not pain, short-term gain for long-term pain rather. I don't know. But yeah, that's definitely something that they should be aware of. So when you decide to do surgery, let's talk a little bit about what robotic assisted surgery is. Can you explain a little bit about the technology behind it?
Yes. So there's a big misconception that robotic surgery consists of a robot doing the surgery and the surgeon kind of just watching this robot.
That's what I initially thought too until I was informed.
Which in the, I believe, 80s, there was robotic joint replacements that were performed completely by the robot in Korea, and they found a tremendous amount of complications. So that obviously fell by the wayside, and in the late 2010s, Mako resurged in the field. Mako is a specific robot with a specific company, and a bunch of other companies came out with robots that essentially do the same thing. For some robots, there's some imaging that's needed before the surgery. You get a CAT scan and sometimes a few extra x-rays to help with the planning process. And then in the surgery, after the surgeon does the approach, gets the knee or the hip exposed, they take a probe that has an infrared sensor on it and they map out the joint. And that sensor speaks to the robot and the computer attached to the robot. And it connects the mapping that we do intraoperatively to the imaging we get preoperatively. And then we can see exactly where the prosthesis is going to go intraoperatively, and we can change it. We could change by 1 degree, we can change by half a degree, we can change by 5 degrees. And we know where it's going to go, and we know how it's supposed to look relative to the bone after we put it in. So that is essentially the crux of what robotics is. It gives you more accurate information about what you're doing as opposed to kind of using these jigs that help us cut and then eyeballing if we're putting the prosthesis in the right place.
So the role of the surgeon, you're guiding the system. And as you're saying, the advantages for robotics, there's precision there. Like, so if someone wanted to ask you what's the advantage of traditional surgery versus robotic, what would that be? What would that answer be?
It's hard to give a definitive answer because our research surrounding robotics is relatively young in the orthopedic field. Our preliminary data, which is 10-ish to 15 years, shows that robotics helps us be more accurate in our positioning. It allows less soft tissue dissection. And so theoretically, you have less pain post-operatively because you don't have to take off so much soft tissue to expose what you need to see. And in some studies, there's been less opiate requirement for patients post-operatively. But from a functional perspective, traditional and robotics are no different in the long term.
Okay. So whether it's robotic or traditional, the joint lasts the same and the surgery outcomes are, it's less recovery time with the robotic surgery.
I'll say yes to the second part. I'm not sure about the first part because we still only have 15-year data. So a lot of patients come in and say, how long is this knee or hip going to last me? And we have data on the traditional stuff with hips or knees. We have 20, 30-year data, and we just don't have that with robotic assistance. We presume it's going to last longer because we know exactly where we're putting it, taking less bone. It's in a more kinematic or in an alignment that is more tailored to the patient. So we assume it's going to last longer, but we don't have that definitive answer yet.
So how do you decide which patient is a candidate for robotic surgery? Or is that just a choice you make with the patient?
So unless a patient has a significant deformity, meaning their knee is severely knock-kneed and would require a lot of correction, I recommend robotics to everyone. The only other patient who wouldn't get robotics would be a revision patient, meaning they need a redo of their joint. And one of the reasons for that is the revision software is still being developed. And so you go back to the traditional way of doing the redo.
So we talked a lot about the benefits of the robotic surgery. What does it look like for a patient after surgery? Can they return to their quality of life? Does robotic surgery help them return to quality of life any differently than traditional?
So this kind of goes back to the functional recovery post-operatively. There are studies that show that some patients do recover more rapidly because of that limited soft tissue dissection.
Yeah.
But from a long-term perspective, the patients will eventually, up to 10, 15-year data from what we have, they'll reach a similar threshold to the traditional. The only difference I'll say is if you're doing a minimally invasive approach, like for a partial knee replacement, for example, you have to put pins in the thigh bone and the shin bone so that way the robot knows where the leg is in space. So if you're doing a mini incision, you can't put those pins within the incision. So those patients might have a couple of incisions up on the thigh bone or down on the shin bone. So they have an extra 2 dressings. So that would just be, something to watch out for.
And you mentioned earlier that some patients think that it's an actual robot. Well, what are some of the other misconceptions that you might hear patients saying about the robotic surgery?
That's really the big one is the robot doing the surgery on its own.
Yeah.
It's really a robotic arm,
Yeah.
and it has haptic boundaries, meaning it creates these boundaries based on all the data that we talked about that was input based on the patient's knee, where the saw can and can't go. But we're controlling how much of a bony resection we're taking, and we're controlling the saw itself. It can't turn on without the surgeon. And when you do a lot of these, you get a sense if something is off. So you could always abort the robot, have them pull it out, and go back to traditional instrumentation if you need to.
That's great to know. I didn't know that at all. Interesting. So what are some of the things that might be some advancements, let's say that, some advancements in robotic surgery that you're excited about?
The biggest 2, I would say, are the hip replacement, because the hip replacement, you get the CT scan of the leg, but you also get x-rays of a patient when they're seated and when they're standing. And that shows how the pelvis moves and gives you a sense of what's going to happen to the cup of the total hip when they transition their position. That's important because some patients have more arthritis in their spine or less arthritis and have more motion. And so the amount that the pelvis is going to move is going to dictate how much that cup moves.
Yeah.
So we have a lot more information when we're putting in the cup. So from a hip side and a primary knee replacement or joint replacement rather, the hip technology is very impressive. From a future perspective, the implementation of the revision system is very exciting. There is some research being done on augmented reality, which people are probably familiar with the Apple Vision Pro or the that other Microsoft one, basically the goggles that go on your eyes. And you do get a CT scan before the surgery, but in the surgery, it projects a hologram on the patient that you see through your goggles. And so you can basically do the same positioning. The advantage of that is you don't need a big robot, you just have the goggles. But there's still research being done to see how accurate it is relative to the robot.
So going back to the part of your answer about the imaging of them standing versus lying down, that was really interesting because I heard a piece of that in a talk that you gave to some seniors recently about robotic surgery. And I was like, wow, that's like one of those I don't know what I don't know type of things. Is that type of x-ray and, image something standard that every physician doing robotic surgery, like that a patient should expect to receive, or is that part of your technique?
It is not standard for everyone, actually.
Okay.
The sit-stand films, what we call them, basically does what I was explaining. Is it shows the pelvic motion. And from that, we calculate specific numbers. And intraoperatively, we can go through something called a virtual range of motion. So we could see where the leg is going to impinge or hit on the cup, and then we can adjust the cup because of that information.
Yeah.
Not a lot of people use that intraoperatively, even when they are using robotics.
I just was like, wow, that's a really interesting thing to know because, as a patient, you go in and you see a doctor and, you follow what the protocol they suggest, but you really have to be your own advocate these days. And that falls under the, like I said, for me, the don't know what I don't know type of thing. And that, to me, it seems like that type of outcome, that the patient's outcome would be so much better based on you really looking at the full anatomy and movement. So I was really enjoying listening to that talk. It was really interesting. But if you were speaking to a group of medical students interested in pursuing your field in orthopedics, what advice would you give them?
Pursuing orthopedics is very different than pursuing joints. For medical school, I'd say you need to focus on your grades and on your standardized exams first. To get into orthopedics.
Yeah.
Orthopedics is a very competitive field, and the way that the board examination has kind of shifted over the past 5 years or so, the way that students are now being assessed is changing. So if someone is very passionate about a field, obviously do your studies, but try and get involved early as well.
Yeah.
Make sure that you actually want to do this because it's a long path.
Yeah.
And you don't want to be 2-3 years in and realize you really don't want to be in a field.
What is the most rewarding part of your job?
Seeing patients post-operatively.
Yeah.
Their lives completely change.
Yeah, that's, I'm sure, very rewarding. And do you feel like your patients realize that impact as well, that their life, I mean, with the robotic surgery versus traditional surgery, do you see a difference at all in anyone being able to return to their quality of life?
I'm a little biased because I try and do everything robotic.
Yeah.
I just think it's better and more accurate in my hands. So the patients that are being done traditionally are actually revision patients.
Okay.
So they have a total knee
Yeah.
and it's infected or it was loose or something happened and they need a redo. And the recovery process for that and the risk profile for those patients is very different than for a primary replacement.
Yeah. That's great information. Is there anything additional that you'd like to share with our listeners that we might not have covered today? We have all these beautiful models here.
Yeah, from a robotic perspective, I just think it's important to understand what robotics actually is. From a surgical perspective, we have a couple models here. So this is a total knee replacement.
Yeah.
The total knee consists of actually a resurfacing surgery. A lot of people think that they're coming in and you're cutting out the knee and you're giving them a totally new knee. And that's not what's happening. We come in here and resurface the bone to create platforms. And then these metal components sit on the bone and you have a plastic piece that sits in between. So by definition, you're getting rid of the arthritis. Mm-hmm. So this is what a total knee replacement looks like, where you're totally replacing the knee.
Yeah.
But you also have a partial knee replacement. And this is typically used for younger patients who are having symptoms in just one of the 3 compartments of the knee. The 3 compartments consist of the inside of the knee, the outside of the knee, and then under the kneecap or the patellofemoral compartment. If a patient's only having symptoms in one part of the knee, you don't have to replace everything. You can just replace just that one compartment.
Yeah.
So this has 2 compartments replaced, but you replace, for example, the medial compartment, and you leave the rest of the knee intact. You leave their ACL, their PCL, and all the other ligaments and muscles and tendons that cross the knee. The nice thing about that is it's a much more reserved or conservative bony resection. And then when you convert this to a total knee, if a patient does have progression of arthritis, it doesn't require the significant surgery that a total knee would need to be redone.
Yeah.
You could actually use the same prosthesis. And a lot of patients ask, what's the survival rate? How long is this going to last me if I go partial knee? I don't want to keep having surgeries.
Yeah.
And there's a recent study, 2024, I think it's the Journal of Arthroplasty, if I'm not mistaken, that showed a 99% survival rate at 10 years. Again, it's only 10 years, but that's pretty good to know that without complication, meaning no fractures or infections or anything wild that happens, it should last 10 years at least.
That's good stuff. That's good stuff. Well, I think we covered a lot today. We have a pretty good understanding of how the robotic surgery compares to traditional and hip and joint replacements, hip and knee replacements. So thank you for sharing your insight today on total joint replacement and arthritis. And that's all the time we have for today. So if you or someone you know is suffering from joint pain, stiffness, or just reduced mobility, call 856-690-1616 and come have a consultation with Dr. Albana. He's new to the practice and brings a lot of great talent to the practice. And, we're really excited to have him on board. So we look forward to seeing you in our office. We have 12 offices throughout southern New Jersey, in Atlantic County, Gloucester County, Camden County, Cumberland County. So, and Salem. I think I mentioned Salem, but we are here for you. Access to care is what we really pride ourselves in. You can also go on our website at poasnj.com and schedule an appointment there as well. So thank you for being a part of our podcast today and hearing what we have to talk about with Dr. Albana. We look forward to seeing you in the office. Until next time, stay safe and keep healthy.